Okay, thank you very much, Mr. Chairman. It's a great honor for me to participate in this Congress of the Korean Society of Phlebology. And in the next minutes, I will try to transmit you my experience with Flebogrif. Those are my disclosures, and those are the main topics that we'll go through. The first pilot study that was published in 2015, it was done with a previous Flebogrif device. And it wasn't until 2016 that we had the first 3 months clinical results from the team of Professor Tomasz Zubilewicz. Flebogrif device is considered a MOCA device because it has 5 metallic eroding elements that produce a mechanical harm in the inner wall of the vein while we inject foam. It's produced in 2 different lengths, 60 and 90 centimeters. And to expose the metallic elements, we have to do a strict pullback maneuver to expose them, and taking care not to push the hooks into the vein wall. It goes through a 10 centimeter introducer, and we have to be aware when performing the ablation to stop whenever we see this 10 centimeters solid mark. The Flebogrif device comes in a set that contains everything that we need to perform the ablation. As any other endovenous procedure, we have to start with an ultrasound-guided puncture of the vein, and when we are in the vein, we go up over the wire all the way to the SFG. Once we're getting close to the SFG, we can confirm our position with the ultrasound marker. That is very useful. And once we are there, we can perform this pullback maneuver, as seen in the video. It's very important to remember to screw on the two-way valve to avoid getting the metallic elements again into the catheter when we pull from it. And at that moment, we can already withdraw the guide wire. And then finally, start the ablation. We will start 2 to 3 centimeters from the SFG. And we can do it either by ourselves or ideally having someone to hold the introducer and to compress the SFG with the ultrasound probe. The ablation speed is supposed to be 5 centimeters per second. There are some authors and myself that prefer to do it slower, at a rate of 1 centimeter per second. I also like to draw a line that tells me where is the halfway of the ablation, so I can better distribute the foam. Even so, it's very fast. To do a 40 centimeter saphenous vein, it takes 40 seconds. With the other speed rate, it takes 8 seconds, compared to, for example, other MOCA methods that would take around 4 minutes. And this is how it should look, the vein after the ablation. This is the same vein that we have up there, with a good distribution of the foam and a good spasm. Okay. Foam is a crucial ingredient of the procedure, and we have to pay attention at the quality of the foam. Normally, 3% foam is recommended. We can use 2% polydocanol foam also for smaller veins. So, as I was saying, we have to pay attention to the quality of the foam, avoiding using too liquid foam. But this is easier to solve. We can even add a 5 microns brown filter that will improve the quality of this same foam. And if we can, even better, if we can use Varicio system. Okay. This is the 1 month appearance, ultrasound appearance of the vein. We will see a more heterogeneous and more echogenic image of the vein compared to what we are used for with Clarivene, for example. And one of the weakest points of Flebogrif is the lack of literature. There are not many studies about Flebogrif. In one recent meta-analysis, they reported a 12-month 93.2 success rate. And in the longest series that we have, also from the team of Thomas Subilevich, a 36-month follow-up, they reported a 92% anatomical success rate. In our experience of about 310 cases that are done in different hospitals and clinics, we saw a big difference in the 3 months occlusion rate that we were having as we were changing the protocol. What we changed, we uppered the polydocanol concentration. We shift from 2 to 3%. We start doing double passage technique that I will explain you. And we start lowering down the speed of ablation from 5 to 1 second per centimeter. Let's talk about different features of the device. The Flebogrif, when it's displayed, it describes a very big circumference. So it's a very good option for large diameter saphenous veins. But in those cases, it's mandatory to do this double passage technique. That means exposing the metallic elements and doing a first retrieval of the device. And we see how the vein goes spasm. And then going back again and doing the normal procedure, as we see here. We have to be aware that the foam that we are injecting in the saphenous trunk will or can migrate to other N3 branches. That we can find those branches that are afterwards occluded. Fact that can be very helpful, like this patient at 1 month control after only the Flebogrif passage. It was a 24 diameter gray saphenous vein, and most of the N3 were already occluded. But it can be also too strong, and we can have thrombophlebitis and discoloration. So there are ways to solve this. For example, in this case, I didn't want the foam to go over, so I was putting a drop of glue at the origin of the branch. But you can do hand compression, you can do tumescence, or even injecting a low concentration foam to get some spasm. If you are doing phlebectomies, it's not so important, this fact, because you are going to take away the N3 branches. Today we know that C5 and C6 are the new C2, so a lot of effort is made to help those patients. And in that sense, MOCA techniques are ideal for those patients because we can perform long ablations from either antegrade long ablation from the malleolus, or we can do also from a retrograde access to treat the distal part, the perforators, or the periulcus plexus, okay? Or we can combine them using an antegrade approach to treat the saphenous trunk, and then retrograde to treat the perforators, if there are, and the periulcer plexus. Performing bilateral treatments is a matter of volume of foam. In general, we are allowed to use 10 milliliters of foam per day. It's true that European guidelines let us increase this volume in selected cases. When we do so, we prefer to use physiological gases free of nitrogen. Hyperpigmentation can occur up to 10 to 12% of the cases, so we have to be aware of this, especially with the veins that are very close to the skin, and we can lower concentration there a little bit. And one of my favorite indications for Flebogrif is a TIVA surgery relapse with growing cavernoma, because you can go up with the device, inject a bolus of foam, treat the cavernoma, and then perform the regular ablation. Oh, can you, the sound? And you see how the foam spreads all over the cavernome. Okay. In general, with good results, especially when we add additional sclerotherapy sessions. There are new potential applications of the Flebogrif catheter, since it goes over at 0.35 guide wire and it is available in a 90 centimeters length. We can explore our other venous territories as the gonadal veins. This was a case that we were doing normal left gonadal vein embolization with coils, and then we found a pretty straight and good caliber right gonadal vein, so I decided to do MOCA on those in this vein, doing a first passage before to get a spasm, and then the second one injecting the foam. Okay. This patient had to undergo a CT scanner 1 year after for other reason, and we saw how the right gonadal vein was almost disappeared. So that's the difference between leaving metallic material on or not. Well, to conclude, Flebogrif is simple, safe, and effective device that offers the advantages of MOCA procedures, especially when we're in the venous ulcers management. In our experience, a slower ablation speed, high concentration foam, and performing double passage technique help to obtain better results. We have to be aware that foam can migrate to N3 branches. Further studies are needed to confirm long-term occlusion rate, but existing data is promising. And as an over-the-wire catheter offers new potential applications. Thank you very much.